Hello everyone, today we are gonna talk about topic number 18. It's anesthesiology, lecturer Shevchenko Alexander, Baltic Federal University, Medical Institute, Kaliningrad, 2020. So we must talk a little about narcosis, history of narcosis. From the ancient times, people want to do procedures, medical procedures, without any pain. And this is really easy to understand, and that is why people try to find something which drugs which provide narcosis or anesthesia. The word narcosis comes from Greek narke, which means numbness, a condition characterized by a temporary shutdown of consciousness, pain, sensitivity, reflexes and relaxations of skeletal muscles, caused by the effects of narcotic substances and reversible depression of the central nervous system. Until the middle of the 19th century, no anesthesia was known and did not even assume that it would ever be possible to operate in such a way that the patient was safe and not painful, and the doctor was comfortable. But this is not fully correct. From the time of ancient Egypt, people know about opium milk, and they know if you feel pain, you can drink some opium milk to have a pain relief. So slightly different action of opium than a narcosis, but people know about something, some substances which can give pain relief. The official date of the bean or the anesthetic era is October 16, 1846, when the American Dr. John Warren first operated on a patient under ether, this reads like ether anesthesia. The inventors of anesthesia are recognized as William Morton, a dentist by profession, and his teacher, Doctor and chemist Charles Jackson, who proposed the use of ether. However, as early as 1780s, the English chemist Humphrey Davy, testing nitrous oxide on himself, wrote, "Nitrous oxide seems to have the properties to destroy pain." But no one paid any attention to his words. A dentist from Connecticut, Horace Wells, asked his colleague John Riggs to remove his bad tooth during the action of nitrous oxide, which was done in 1844. He felt no pain, which prompted Well to use nitrous oxide in his practice. So, what does mean narcosis in modern times? Narcosis is artificially induced reversible state of central nervous system inhibition, in which sleep occurs, loss of consciousness and memory, amnesia, relaxation of the skeletal muscles, reduction or disabling of central reflexes, and pain sensitivity disappears. General anesthesia occurs. All of this occurs when one or more general anesthetics are administered, the optimal dose and combination of which is selected by the anesthesiologist, taking into account the individual characteristics of a particular patient and depending on the type of medical procedure. We must define terms narcosis and anesthesia. So anesthesia or local anesthesia, the process of reducing the sensitivity of the body or its part until the complete cessation of perception of information about the environment and their own state. Sometimes people use word narcosis but want to say anesthesia, or vice versa. They want to say anesthesia but say narcosis. We can use word general anesthesia if we mean narcosis, and a local or regional anesthesia if we talk about anesthesia. Okay? Combined narcosis. I want to give you some definitions which you need to know if you want to read something about narcosis or anesthesia at all. And I want to give you a basics concepts with which you can understand basics of anesthesiology. So, combined narcosis. A broad concept that implies the sequential or simultaneous use of various anesthetics, as well as their combination with other drugs. Analgesics, tranquilizers, muscle relaxants that provide or enhance individual components of anesthesia. In an effort to combine different anesthetics, the idea is to get from each drug only the effect that is best provided by this substance, to enhance the weak effects of one anesthetic at the expense of another, while simultaneously reducing the concentration or dose of the anesthetics used. Premedication. Medical preparation of the patient for surgery and anesthetic aid. Depending on the purpose, premedication can be specific or non-specific. Non-specific premedication. The purpose of non-specific premedication is to relieve mental stress, provide rest for the patient before surgery, normalize the level of metabolic processes, which reduce the consumption of general anesthetics, prevents undesirable neurovegative reaction, side effects of narcotic substances. General and local anesthetics reduce salivation, bronchial secretion and sweating. This is achieved by using a complex of pharmacological drugs that have a potential effect: sleeping pills, antihistamines, narcotic analgesics, tranquilizers, and cholinergic agents. For example, how we can reduce saline production. We can give the patient atropine, and when we inject the atropine, salivation is reduced. Specific premedication. It is used in patients with comorbidities and is intended to prevent exacerbation of chronic diseases before, during surgery, and in the early postoperative period. Easiest example in this rule: if we have patient with hypertonia, we can give antihypertonic drugs, beta blockers, or inhibitors of angiotensin performed enzyme. We can use this we can use these drugs to reduce high blood pressure, or we can use inhalers in case of bronchial asthma. We have three main types of narcosis. Inhalation. The introduction of drugs is carried out through the respiratory tract. Depending on the method of introduction of gases, there are mask endotracheal and endobronchial. Non-inhalation, intravenous with a ventilator, intramuscular, rectal, etc. And combined anesthesia. Analgesia is achieved by the consistent use of various drugs and methods of their administration. Here we see stage of after premedication. Anesthetist, nurse or anesthesiologist give the patient high concentrated oxygen, and after this usually we intubate patient. First anesthesia was made by Guido. First classification of stages of anesthesia made by Guido, and he used ether tool. We have four main stages. Stage first, stage of analgesia or disorientation, from beginning of induction of general anesthesia to loss of consciousness. Joseph Artuzio further divided the first stage in Guido's classification into three planes, into three sub-stages. At first, the patient does not experience amnesia or analgesia. Second, the patient is completely amnesic but experiences only partial analgesia. And third plane, the patient has complete analgesia and amnesia. Second stage, stage of excitement or delirium, from loss of consciousness to onset of anatomic breathing. Eyelash reflex disappear, but other reflexes remain intact, and coughing, vomiting, and struggling may occur. Respiration can be irregular with breath holding. Stage 3. Stage of surgical anesthesia, from onset of an automatic respiration to respiratory paralysis. It is divided into four planes. First stage, from onset of an automatic respiration to cessation of eyeball movements. Eyelid reflex is lost. Swallowing reflex disappears. Marked eyeball movement may occur with conjunctival reflex is lost at the bottom of the plane. Second plane, from cessation of eyeball movements to beginning of paralysis of intercostal muscles. Laryngeal reflex is lost. All the inflammation of the upper respiratory tract increases reflex and irritability. Corneal reflex disappears. Secretion of tears increase, a useful sign of light anesthesia. Respiration is automatic and regular movement, and deep breathing as a response to skin simulation disappears. Plane 3. From beginning to completion of intercostal muscle paralysis, diaphragmatic respiration persists, but there is progressive intercostal paralysis. Pupils dilated and light reflex is abolished. The laryngeal reflex lost in plane. It can still be initiated by painful stimuli arising from the dilatation of anus or cervix. This was the desired plane for surgery when muscle relaxants were not used. Plane 4. From complete intercostal paralysis to diaphragmatic paralysis or apnea. We see like very wide pupil, distension of pupil. Sometimes you can see this in movies when people say about drug overdose, and sometimes you can see this in your clinical practice when we expect brain death. We have so wide pupils. I made this picture here because stage 4 it have no difference between drug overdose with overdose in the operating theater. Stage 4. From stoppage of respiration till death. Anesthetic overdose caused medullary paralysis with respiratory arrest and vasomotor collapse. Pupils are widely dilated and muscles are relaxed. So we have different stages, and here you can see specific charts of respiration rate, eye activity, pupil reflexes, how dilated our pupil, lid reflex. To take lid reflex, we must touch to the corner of the eyelid, and if people closed their eyelids, we have positive reflex, and if we didn't expect that, we didn't see the reaction, so we didn't have positive eyelid reflex. And I wanna say quite a few words more. You have question in your exam questions for exam. Describe modern multi-component narcosis, and what do you stages of multimodal multi-component narcosis. What you must say? You must talk about stages of anesthesia by Guido, but you must say what in modern multimodal narcosis we use myorelaxants, so we try to eliminate second stage and go from the first stage, so analgesia and amnesia, right to the third stage of surgical anesthesia. This is all what we changed during this time, because anyone didn't want to see delirium, because in this stage patient can try to run out from the operating table, or patient can vomit, or take some IV line from his vein, and maybe severe bleeding can occur. So we didn't want to wait second stage when it comes to the third. We want to eliminate it at all. We want first stage and then third stage. So first stage of analgesia and amnesia, second stage of delirium, third stage surgical anesthesia, and third stoppage of respiration, or this stage called diaphragmatic paralysis or overdose. Now, because of the use of the intravenous induction agents with muscle relaxant and the discontinuation of ether, elements of Guido's classifications have been suppressed by depth of anesthesia monitoring devices such as BIS monitor. But you will not be rely so high on the BIS monitor, but because it's not so relevant right now. And what else do anesthesiologists? They provide artificial ventilation. It means of assisting or stimulating respiration, a metabolic process referring to the overall exchange of gases in the body by pulmonary ventilation, external respiration and internal respiration. A ventilator is a machine that provides mechanical ventilation by moving breathable air into and out of the lungs to deliver breath to a patient who is physically unable to breathe or breathing insufficiently. If we didn't have or didn't need artificial ventilation by the artificial ventilation apparatus, we can use ambu bag in the field or in the another department of the hospital while we track patient to the intensive care unit. Patient can also be ventilated with a simple hand-operated bag valve mask. As we see, it has three components: joint with valve, mask, and bag. We must very dense put this mask on the patient face and press by hand on this valve, on this bag, sorry, to inhale air to the lungs of the patient. Laryngoscopes. It consists of two parts which connected with each other, and we can use laryngoscope to provide intubation of trachea, because with laryngoscope we can visualize the vocal cords. Tracheal tube. Tracheal tube is a catheter that is inserted into the trachea for the primary purpose of establishing and maintaining a patent airway, and to ensure the adequate exchange of oxygen and carbon dioxide. As you see, we have a special tube, and we have bubble on the end of the endotracheal tube, and we need to insert some air into this bubble to fix endotracheal tube into the trachea, because if we didn't give some air to this bubble, endotracheal tube can go out from the trachea and our patient will be dead.
We want to make sure that we have a tube in the trachea with the cuff inflated. That's the definition of a secure airway. As you prepare, you want to make sure all your equipment is ready to go. The laryngoscope is powered, the bulb is working. Endotracheal tube with a stylet in place. The tip of the stylet, of course, recessed from the end of the tube. Inflate your cuff to make sure that it's working. Suction is available as well. Normally, your resuscitation team would be bagging the patient. When you're prepared, the guideline is for the provider to take a deep breath and hold it just as your patient will be holding the breath as you prepare to do your intubation. With the head slightly tilted, making sure that suction is applied so all the secretions are out of the way, the laryngoscope blade is introduced, the tongue is swept to the right, and the elevation on the laryngoscope blade goes up and away from the patient, not cranking on the teeth. Visualizing the cords, I place the tube and watch the cuff go inside the cords. Stylet comes out, cuff is inflated, and patient is ventilated. Watch for rise and fall of the chest, and then auscultate to hear breath sounds on each side with no borborygmi. An additional device is the end-tidal CO2 monitor. Once the patient has been intubated successfully, this device allows you to double check and make sure that you're in the trachea. By placing this device between the endotracheal tube and your bag, you're able to watch for a color change that occurs that witnesses the CO2 level rising with your resuscitation. Normally the color is purple when it comes out of the bag, showing low CO2 concentrations, and you expect to see this change from purple to tan to yellow, letting you know that you have successful intubation.
Okay, I hope you understand how we can intubate the patient. Another one tip, sometimes in the emergency when patient unconscious, or when our patient eats some food before operation, we must make Serix maneuver. The pressure is placed on the cricoid cartilage, compressing the esophagus, which reduces regurgitation and helps bring the vocal cords into view. So you see, as on the scheme, we place our fingers to the cricoid cartilage and press it down. And another video.
An assistant should apply the Selleck maneuver by applying firm pressure to the cricoid cartilage. The Selleck maneuver compresses the soft wall esophagus between the cricoid cartilage and the cervical vertebrae, theoretically preventing passive regurgitation of gastric contents.
So next, we must meet central regional anesthesia. Regional anesthesia, central, divide to spinal cord or blocking the transmission of impulse at the level of the roots of the spinal nerves by injection and anesthetic into the subarachnoid space. It occurs quickly and is used for operations below the navel. Epidural anesthesia, blocking the transmission of impulse at the level of the spinal nerve roots by injecting an anesthetic into the epidural space. Comes slowly, acts segmentally. The patient can walk and cow down. A special case of epidural anesthesia at the level of the sacrum. And combined spinal epidural anesthesia, a combination of the advantages of spinal, high speed of block development, and epidural, the possibility of long-term anesthesia. Because we can leave the epidural catheter into the epidural space, and we can inject some additional drugs into this catheter. So our anesthesia in this case will be prolonged. Peripheral or regional anesthesia. Peripheral regional. Conductor anesthesia, blocking the transmission of an impulse at the level of the nerve trunk or nerve plexuses. For example, blockage of the bronchial plexus during operations on the upper limb. Local infiltration anesthesia, blocking the transmission of impulse at the level of pain receptors and small nerve branches. It is achieved by introducing a solution of local anesthetic intradermal or in the submucosal base. And contact anesthesia or application. Sometimes we use high concentrated lidocaine to provide anesthesia. For example, in the dentistry, sometimes we may we use spray of lidocaine to the oral cavity, and then only we inject, because when we provide contact anesthesia from the high concentrated lidocaine, 10% concentration, we can inject without any sensation from the side of the patient. Here you see lemon skin. This is a picture which you want to have when you provide local anesthesia. You must understand that only skin, not subcutaneous tissue, have nerve endings. So when you made incision, and if you owe your anesthetic sent to the subcutaneous tissue, subcutaneous fat, patient can and will feel pain. So you must have this picture on the line of your future incision. Another picture for you. I hope you remember these types of anesthesia. So general anesthesia. All patients are sleeping. He haven't any feeling, any sensation. Spinal anesthesia provide anesthesia below the navel. Regional anesthesia below the nipples, and peripheral nerve block we can give the loss of sensation to one of the limb or severally. And local anesthesia, any part of the body. There are the following types of complications: respiratory disorders, disorders of the cardiovascular system, and other complications. Dysfunction of respiratory system, hypercapnia, accumulation of carbon dioxide increases blood pressure, there are extrasystoles, delayed awakening after surgery, possible edema, swelling of the brain, violation of the free passage of the respiratory tract, tongue entrapment, foreign bodies and blood, mucus, sputum, saliva, laryngospasm, spasm of the larynx characterized by closure of the vocal cords, bronchospasm, spasm of the bronchi and increased sputum production, aspiration of gastric contents or vomiting for the prevention of regurgitation and aspiration on the introductory anesthesia. In some cases the Select maneuver is used. Disorders of the cardiovascular system: arterial hypotension, low blood pressure, arterial hypertension, on the contrary, an increase in the blood pressure, often happens due to the excitement before surgery. Violations of the normal pace and rhythm of the heart, tachycardia, bradycardia, arrhythmia, acute myocardial infarction, pulmonary edema, pulmonary embolism occurs infrequently in anesthetic practice, but there is a high probability of death. Other: acute adrenal insufficiency treated with large doses of hormones, overdose of analgesics, violation of thermoregulation. Anesthesia makes the body more vulnerable to external temperature influences than usual, so hyper or hypothermia may occur when the conditions of the heart transfer or heart formation change. Hiccup and allergic reactions up to anaphylactic shock, in particular severe cases. Awareness under anesthesia, awakening during a surgical operation, may not be noticed by the anesthesiologist. In various cases, the patient may experience pain, hear sounds, and remember events that occurred to him during the operation. Recovery, the consciousness, is a complication of anesthesia which does not carry an immediate threat to human life, but can cause psychological problems up to mental disorders. Thank you for your attention. I hope you learned something new from this video. Goodbye.